before we talk about cough, let's just revise our cough reflex a little bit more. What is cough reflex? It is basically a protective reflex which is present to prevent aspiration of foreign bodies and to expectorate secretions which are built up inside our airways. So the airways are innervated by sensory neurons, activation of which is carried out via the vagus nerve and to the brainstem and the higher centers. Whenever the airways sense an irritant, noxious or mechanical stimuli through the receptors on their nerve terminals, in health or disease, stimulation of these will lead to an urge to cough, which is basically to expectorate whichever is foreign to the airway. And this is associated with a tickling sensation in the throat, which leads to coughing. So the mechanisms of cough goes through 4 phases. First of all is the irritation phase, where the neural activation from solitary nucleus is done, and this can be cortically suppressed. So the reason we have to know this is, where is the cough originating and how can you suppress it? In the inspiratory phase, what happens? There's a brief inspiration where the glottis opens, the diaphragm contacts, and the thoracic cage expands. This is very quickly followed by the compressive phase, where the abdominal and thoracic muscles compress air against a closed glottis. And that leads to expulsive phase, where abruptly the glottis opens, and that is where the sound of the cough comes by rapid exhalation from high velocity shear force, allowing airway clearance. So these are the 4 phases of coughing: irritation, short inspiratory phase, significant compressive phase, and a prolonged expulsive phase, which produces the sound and the coughing. And the cough stimulation, as we said, it can be central, it can be from the cough receptor fibers in the airways and cough sensitivity receptors in the airway mucosa, stimulated by irritants such as capsaicin, such as acid. Inflammatory stimulants can be bradykinin and prostaglandin E2, and mechanically, as in air pollution caused by particulates, by smoking, as in liquid nicotine and low chloride levels. So these are the stimulants which can irritate either the neural system, which then through cough fibers, the cough receptors in the airways, and then air mucosa, which are cough sensitive, lead to coughing. Okay. Now, clinical terms over a period of time that have developed, and we have already discussed this in our first slide, is when is a chronic cough, what is a dry cough, what is a productive cough. Amongst these, cough hypersensitivity is something which is progressively increasing as the years go by in the published data that we are having, which basically tells us that environmental factors, noxious stimuli are causing significant amount of cough hypersensitivity and laryngeal hypersensitivity that account for a significant population of patients presenting with cough due to other things. Let's first talk about approach to cough, chronic cough in an adult. So how do you investigate a chronic cough? In a very nutshell, you review the history. First of all, find out if there is any identifiable cause for cough. For example, is the patient a current smoker, or is there any history of previous smoking? Are they on any medications that might be causing cough, such as an angiotensin converting enzyme inhibitor? Whether there is any history of gastroesophageal reflux or not, whether there is any history of postnasal drip, upper airway cough syndrome or not, and if they have any intermittent features such as asthma-like symptoms, which are cough, wheezing, and shortness of breath, which are intermittent and the patient is well between. If after this, you obtain a chest X-ray, if the chest X-ray shows any abnormalities, such as bronchiectasis, such as pneumonia, such as pleural effusion, then you treat that. If there is, especially in our country, if you find any evidence to suggest there might be tuberculosis, then you will consider AFP smear or sputum testing in any cough that is more than 2 weeks in duration. You may need to do a high-resolution CT scan if you are suspecting bronchiectasis or interstitial lung disease. You may need to do bronchoscopy with biopsy or lavage if you are suspecting any malignancy or interstitial lung disease, and sometimes may need to even go to other things such as VATS biopsy. We will leave it there. If the chest X-ray is unremarkable, then you first rule out any drug-induced cause or not. If it is not there, then you stop the ACE inhibitor. You definitely, in all these patients, will do a spirometry, because sometimes asthma might be the only presenting symptom of cough, if they are smoking, you give them smoking cessation advice. And if everything is still normal, you give them a therapeutic trial of 4 weeks of inhaled bronchodilators and steroids. If there are GRD symptoms, then you give them therapeutic trials of pH suppression with a PPI or a proton pump inhibitor, with or without pro-motility agents. If they are refractory, in 6 weeks' time, if the cough is not getting better, you refer them to a specialist for an upper GI endoscopy, plus minus pH studies if necessary. If the patient is clearly giving history that when they lie down, they are having cough, it is a nocturnal cough, and there is a history suggestive of sinus symptoms, you give them a therapeutic trial of nasal, intranasal corticosteroids, and you may need to do allergen testing such as dust mite allergy testing, because without removal of the allergen, the cough will not get better. And asthma symptoms, as we have already discussed, if you are present, then you treat them. So, as we just said, that diagnosis, whatever we did, first of all, you try and identify the obvious cause. You do investigations with or without empirical treatment for the common causes. If they are still no better, how soon would you see them? At least 4 to 6 weeks later. You do further investigations. And if it is still negative, this is a good 3 months later. That's when you label them unexplained chronic cough. And trust me, very, very, very few patients will fall in this category. Most will have one phenotype or the other. And that is our job, to find out which phenotype they fall in.